like soldiers in their nice clothes, like soldiers in their nice clothes, together. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest, like sailors in a tempest, together. And it could be just you and me. We'll be family. Just wait and see. So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Evening, everyone. Welcome to tonight's Lung Cancer Living Room. Happy to have all of you in the room. Those of you joining us online via YouTube and Facebook Live, welcome, welcome. For those of you who may not know me, I am Danielle Hicks, and I oversee patient program services and education here at the Adario Lung Cancer Foundation. I am also one of Bonnie's daughters.
The oldest.
The oldest daughter. The youngest one, who most of you know, couldn't be here tonight. She fell ill.
Right.
So I was ill last month. It's her turn this month. We're so excited to have you all here tonight to talk about science in early detection of recurrence and companion diagnostics. It's a blood test to detect this recurrence. So we're really, really excited to talk to you guys about what's going on in that space. We've got Dr. Paul Billings, Joanne, who most of you know. She attends the living room on a regular basis, and Alexey Aleshin. So we're really, really happy to have them here. After we do the Around the Room, I'm going to ask them to introduce themselves, talk a little bit about why they do what they do, why lung cancer in particular is an important thing to them, and then we'll go into tonight's presentation. Do you want to introduce yourself before we do the Around the Room?
No, I'm Bonnie. You guys all know who I am. Most of you, anyway.
Yeah. What about the people online?
They know who I am too.
Oh, okay. Yeah. Everybody knows Bonnie. Wait, that's not false.
No.
With that being said, we'll go ahead and start the Around the Room. Just a reminder, Bridget already reminded you guys, please pick up your mics when you're giving your updates, and silence any cell phones that you might have on, so we don't disturb the folks that are. Are you going to start for us? I'm all ready. I see that. All right.
Ron, of and by and for Joanne. And this is my eldest son, George. Hello. And George and Christina and two little boys live about 20 minutes from us. Sarah and David, Sarah, by the way, works for Natera. Sarah and David have two wonderful little children, 9 and 7 years old, and they live 5 minutes from us.
Not even.
And then 3,000 miles across the country in Manhattan, just north of Manhattan, my other son and his lovely wife, Melissa, and they have 3 wonderful children from university age to high school. And so what Joanne and I have, is a very strong support team. 13 of them at least, ranging from ages university to 4 years old. And by the way, they also, all 13 of them have come out for the last 2 Adario run and walk events.
Yeah, yeah.
And the children, all of them, love them. They have a great time.
That's great.
I should also mention that George and Sarah and Eric have very good, long-lasting friends who have also been a part of that support team. So Joanne, we are not alone. God bless us. And we're going to carry on.
And just add my sister in Mexico, who's also
And
watching.
the sister. Hi, Marion. Okay. You want to say?
Well, I'll say one. I'll be quick. But I know my mom has been at many of these events. This is my first one. I want you to know that she is an overachiever.
We know that.
She won't tell you this, but she was valedictorian at Cal Berkeley, the first woman, double major, spoke in front of the entire Memorial Stadium. Her parents came down from Mount Shasta and had no idea what they'd gotten into. And she has embraced this disease with the exact same vigor. And I'm so proud of her.
Yay, that's awesome. That is awesome.
Wow, how do you follow that? I'm a little teary. That was so sweet. My name is Tina, and I've been in this since 2010 when I was diagnosed with EGFR positive. And I did go through chemo and radiation, and then I started on Tarceva as a maintenance plan, and I am still taking Tarceva every day, so it's working for me. I know it doesn't work for very many, but
How many years, Tina?
8 plus.
Nice.
8 plus.
Nice.
Hi, I'm Sally, and I was found due to early detection. I entered a study, the International Early Lung Cancer Assessment, and after 5 years, one of the nodules grew, and so it was found early. I had surgery, my lower right lobe removed, and it's almost 10 years. So I'm very, very lucky.
Hi, my name is Evie, and I've been coming since 2011. I first started to come with my husband, Neil, who was diagnosed at stage 4. He was EGF positive, and he passed away in July of 2015. And then I was diagnosed with lung cancer, but fortunately I was caught accidentally at stage 1, and I had surgery in June of 2018. And I am NED, and I'm very, very fortunate. And I was also diagnosed as EGFR, same as my husband, but it's not contagious.
Evie, Evie, can you tell a little bit about the accidental diagnosis?
Yes. I had read an article in the newspaper written by 3 doctors in which they talked about a test called a cardiac aorta CT scan with calcium. I believe that was what it was. And it's given to presidents and generals and pilots, and it is to test for risk of heart disease and stroke. And I read this article in February, and in May I went for my Medicare physical, and I showed it to my primary care physician, and I said, I'd like to have this test. And he said, fine. He didn't give me any pushback. He said, I don't think Medicare will pay. And I said, well, that's okay. I want to have this test because I was worried about stroke and heart disease. So the good news was that I came back. No problem, no heart disease, no calcium buildup, no stroke, but you have lung cancer. So they found the mass in my lower left lobe, and I had surgery to remove my lower left lobe on June 19th. And I did not, luckily it was caught so early that I did not need and do not need any additional therapy. So I'm very, very fortunate. And I wish that had been the case with my husband, but it's the difference between early detection and stage 4 detection. And so I'm very interested to hear the speakers this evening.
Thanks.
Thank you.
I think it's important to point out, too, that by today's, standards and requirements to qualify for screening and early detection, you would not qualify.
Right. I definitely would not have qualified, and neither would Ruth Bader Ginsburg.
And you know what's interesting about that? You were qualified to look for heart disease, but you were not qualified to look for lung cancer, right? Which is wrong. We're going to work on that, too. But you are under surveillance.
Yes, I am. Every 6 months, I have CT scans.
So that falls into what you're doing, too.
So, anyway.
Thanks, Evie.
Hi, I'm Rick. I was diagnosed with stage 4 adenocarcinoma back in February of 2015. This has been, it's kind of a milestone month, February, for me, because 4 years ago I was diagnosed. I went through 12 months of chemotherapy, had a little bit of progression, and had my adrenal gland removed, a couple more months of chemotherapy. And 3 years ago this month, it was the first clean scan that I've had. So I'm NED for 3 years right now. So really happy. Feel very blessed and thankful that I was able to find this group 3 or 4 months after my diagnosis to help me wade through all the information that you get bombarded with when you get diagnosed. And the 360 Degrees of Hope book was so helpful for me and my wife. And I hand it out at all the other support groups that I attend to. So
we'll give you a big box when you leave.
Only what I can carry.
Promise.
So, thanks.
Thanks, Rick.
Hello, my name is Johannes Reiter. I'm not a patient, I'm a scientist at Stanford. So my wife has been involved with this foundation for a couple of years, well, I think almost a decade now. She suggested I come here. I just moved from the East Coast to the West Coast. Now I work at the Center for Cancer Early Detection, which is why I'm very much interested in today's discussion. Thank you.
Thank you.
Thank you. Welcome.
I'm Barb Carlin, and I am caregiver for Dave, who is, again, not here this month, not feeling up to it, but I'll try to do the short version. Dave was diagnosed 2 years ago next month with stage 4 adenocarcinoma, metastases to the brain and lymph node. I had very good 18 to 20 months on Tarceva, and that sort of kept things at bay. But when it stopped working, it like hit the brakes. It stopped working. And cancer, as of December, started to progress pretty rapidly, additional lymph nodes into his bone, possible liver. So plus he's also had significant pleural effusion issues. I don't know if any of you have had that, just kind of wanted to raise that, but he's had that drained a few times, had a catheter put in, that failed. So where we are now is now he's got blood clots. He's not feeling real great. His leg looks like a tree trunk. He started chemo last week. So at the Tagrisso, he went on after Tarceva. Apparently it was not working. It continued to progress. So he started carboinolipta last Monday. And then he'll be getting that every 3 weeks. And best news is we had an amazing meeting today with his interventional radiologist where we'd been referred to talk about the blood clots, and he ended up talking about dealing with the pleural effusion and trying to get Dave some short-term relief so he can breathe, because that seems like a modest goal. And so we're continuing to hold on to hope.
Thanks, Barb.
I'm Ina, and next week it'll be 4 years since I had my left upper lobe removed and part of the left lower. And I, like Evie and some of the other people in the room, Sally, had an accidental finding. It wasn't, I know it was a little bit different. It was, I was not feeling well and I had something else. And anyway, I was lucky enough to have surgery and have stage 1 kind of still encapsulated with no involvement other than that. So I also had did not have to have any treatment. And just, came to Bonnie and Dario, I guess it's been almost 2 years now, and feel great to be here and to be part of everyone's story and make new friends and just really try to do what I can to help the organization. And it's an amazing place and lots of wonderful friends.
Yeah, I just have to say one thing, which is that Bonnie apparently has like some sort of weird sixth sense. So like when you get the shittiest report from your doctor, like she emails you 5 minutes later and says, so how are things going? And so that's really important.
Ina, do you want to drop in where you've got that necklace that you always wear?
Oh, yeah.
Yes,
Lovely necklace.
I love this story.
Lovely necklace.
So I know. This was the most amazing. Every year on Veterans Day weekend, so mid-November, there's an amazing fundraiser for this organization at the Fairmont Hotel in San Francisco. It's fabulous, and they have raffles. And actually, it was Dave who talked my husband, Steve, who's been here a few times, some of you know him, into getting the $100 martini glass. He guilted them into it, and we had to leave because we were babysitting for 4 grandsons and left them, so we needed to go. It went on a little longer than we thought, so we left to go home to all these kids because we were going to have them for the next 2 days. And my phone started going crazy as we were getting into the car, and I thought it was a joke.
Right.
And they said, you won, and I really didn't believe them. Barb and Sally were texting and emailing, but yeah. So it's just gorgeous. I wear it all the time, and it's a wonderful way to talk about this organization.
Yeah, when people say, what a lovely necklace, let me tell you.
And everyone does.
Right.
Everyone does. I'm wearing more black than I ever have. Because you have to have your diamonds show up on black. Anyway, yeah, so I'm loving it. I felt guilty of wearing it, but I've gotten used to it.
Don't ever feel guilty.
I know.
That.
It's great.
There's a very generous partner and supporter of the foundation, Jeffrey's Diamonds and Goldsmith, that donates to that raffle every year. So
Yeah, it's amazing.
Big shout out to them.
Yeah.
Right.
Yeah.
Thank you.
You have to buy a $100 martini.
It's worth it.
And then you qualify for the raffle. You
get both.
That's
you
right.
You can get
a
both.
martini too.
Yeah.
Really?
Right.
Oh, yeah, there you go. There you go. Ron, we're going to scoot back there.
Hi, I'm Ron Fong. I'm wearing red because it's Chinese New Year's still.
There you go.
There you
There you go.
You can drag that holiday out for as long as you want. My wife, Joan, was diagnosed stage 4 EGFR, exon 19, and it was discovered by an accident. She had trouble walking, and they thought maybe it was arthritis or too much travel. But at the end of the day, it turned out it was lung cancer that metastasized to her bones, and her hip had fractured, and they couldn't figure it out. And so I'm here because it shouldn't be discovered by accident. We should have ways to solve that. And but she had a good life and got all the way to Plan Q, and so we're good with that. And I'm on Plan R now. Plan R is reinventing Ronnie this year.
Thanks, Ron.
My name is Fred Palmer, and I was diagnosed with non-small cell lung cancer in October of 2013, and I'm currently on immunotherapy.
Thanks, Fred.
Thank you. My name is David Cooling. I'm a representative from Genentech, and just want to say thank you for hosting this event. This is my second living room I've been lucky enough to join, and really appreciate everyone sharing their stories.
Hi, my name is Karen, and as of this month, I'm an 11-year survivor. I had stage 1B. I was an accidental finding. I did go through chemo at the time for 4 or 5 cycles, but and I didn't know about this foundation that many years ago. I wish I had, but I think it's the most incredible thing that I've ever discovered, and I want to do all I can to support it.
Thank you, Karen.
My name is Katerina. I'm here on behalf of my mom, who was diagnosed in November with stage 4 non-small cell lung cancer. She went in for a cough that the doctor just intuitively felt like it sounded weird, so she didn't wave it off and order tests, and that's how we found out. And in April of that year, she had a chest x-ray for something unrelated, which was clear. So it's pretty fast growing. But we feel lucky, or at least I do, that it was even caught in November, because I've heard stories where people are told they have asthma for 6 months. And so I've become very passionate about telling everyone from Uber drivers to people at the MAC makeup counter about this. And actually, I was just down for the race in LA and at the MAC store. And I was kind of in a weird mood, so I decided to apologize to the saleswoman for being a little bit grumpy. And then she told me how her sister had pancreas cancer. And then her colleague told me that her best friend's dad just got diagnosed with stage 4 lung cancer, had back pain. Her brother is in the medical field. And so I told them about the Dario Foundation. So hopefully they'll reach out. And Mom's had her 4th round of carboplatin, Alimta, and Keytruda. This is getting easier each time to remember. Okay. And, we're managing the side effects better. So hoping the next CT scan will show some shrinkage. Fingers crossed.
Thanks, Kenny.
Hi, I'm Evangeline. I was diagnosed 23 months ago with non-small cell lung cancer, adenocarcinoma. And at first, it was thought I was stage 1 or stage 0. But when they saw on the PET scan, it showed it's only contained on my upper left lobe of my lungs. And then they did another scan, which is MRI on my head, and they found out I have 2 tumors in my head, so I was categorized stage 4. I was EGFR mutation positive, so I started Tarceva in May of 2017, and after 11 weeks, it worked. The tumor shrunk by 1 centimeter, and it became dormant until November of 2018. December of 2018, they found out it increased in size. And they found 2 new nodules. So my oncologist assumed that Tarceva is no longer working. So he ordered blood tests, but for EGFR or T790 mutation, but it turned out negative. And so he told me it's either, I have 2 options, either I go to have chemotherapy for 6 cycles or a biopsy. I chose to get a biopsy, in which I'm scheduled on March 4 at Stanford Hospital to have that biopsy done. And from there, only God knows what's going to happen. I just surrender myself, and I just want to let everybody know that this living room hope really did a strong impact in my life. And I found a family who is really caring and concerned about the patient's being. And I thank everybody for all your support and your kind gestures. Thank you.
Thanks, Evangeline. Michelle, does anybody online want to say hello or anything?
Say hi.
Oh, that's cute.
Okay, so with that, we're going to jump into me asking you all, you last, to introduce yourselves and say a little bit about why you're here tonight.
Sure. Wow. I've been here once before. I'll tell you about that in a minute.
Uh-oh.
But I've forgotten about what an honor and how sort of humbling it is for someone like me to come into a group of people like you all and to hear your stories and to be close to you. And I just want to thank you for letting me come back, Bonnie, who I have seen many times since the last time I was here. But thank you very much for sharing, and as we talk a little more over the evening, I hope we can share more. I was here, I think it's about 4 years ago. David Jablins and I, he's a surgeon that Bonnie knows well at UCSF,
We're intimately involved.
Yes, you are. We were developing and commercializing a test for early stage non-small cell lung cancer to classify which early stages needed further treatment and which could just be surgically removed and go on. And that was called pinpoint genomics. It still exists. It's still being developed. Like many things in medicine, it's taken its time. I was the chief medical officer of a company called Life Technologies at the time, which was a pretty large sequencing and molecular diagnostics company. And we then got bought by Thermo Fisher Scientific, and I moved away from the new conglomerate and was sort of consulting and goofing off and maybe thinking about retiring. And then I was approached. I had invested in a company, a few $1,000s here and there I would invest from time to time. In 2006 or 2007, I invested in a company that was trying to develop a new method of molecular diagnosis. It was called, at the time, Gene Security Network. It was run by a very brash South African guy named Matt Rabinowitz. And he was teaching most of the time at Stanford. He was a bioinformatics guy. And he was just a force of nature even back then. And so he talked me out of a few $1,000s of my money. But I stayed close to them and watched them launch a very important test for prenatal diagnosis of the health of the fetus. And they went public in 2015. And then about a year ago, a little more than a year ago, a couple of members of the board who I had become friendly with over the years came to me and they said, we've got this great prenatal franchise, but we're also got some really interesting stuff in cancer and in transplantation, but we don't have a chief medical officer. And would you come and at least look at it and see if it's interesting to you? So I did a little consulting. I found out that they had already reached out to someone who I already known, Alexey here, who I had worked with years before at Life Technologies. And I said, these guys have good taste in physicians, and the technology was really, really promising. So I let them convince me to come out of my sort of semi-retirement. And I've been the chief medical officer and senior vice president of Natera since March of 2018. And it's been an incredible ride. By background, by the way, come from a huge family of physicians. Everybody in my family is physicians. They're all now have passed, sadly, but we used to have little meetings of the AMA at our dinner table. And I'm a geneticist and an internist by clinical trade. I also have a PhD in immunogenetics. And I had a sort of standard academic career, both at Harvard and then later at Stanford, until the 90s, when I became enamored with the biotech industry and with things in biotech and with the speed in which things can get commercialized and get out to people through the biotech industry. And so have been doing more and more projects in biotech, and then finally I gave up academics and most of my clinical practice to work in the biotech industry. So that's me. I'm a Californian, born from Los Angeles, moved up here after I came back from Boston. And I'm very, very pleased to be with you, and I'll have a little more to say as a prelude after my colleagues here introduce themselves.
Great. Thanks, Paul. So again, I'm Alexey Aleshin. I'm the medical director for oncology at Natera. Just a little bit about my background. I actually also went to Cal, so go Bears.
Go Bears.
And at that time, I actually was completely fascinated with actually science, and I was working at a small startup right across the street from Genentech for a summer. And I remember the data that came out initially on some of the early results for actually Tarceva as well as Iressa. And that fascinated me. And actually at that time I said, well, gosh, this is kind of the field I want to go into. So I finished my training at Berkeley and actually went to medical school at UCLA. And again, fell in love with oncology even more. Had the pleasure of working with Dennis Slayman at that time. He's a very famous breast cancer oncologist who actually discovered HER2 and then helped develop a drug called Herceptin. So made up my mind and actually was fortunate enough to come to Stanford for my internal medicine training and stay on there for fellowship in both medical oncology as well as hematology. And had the pleasure of working with many thoracic oncology patients during my training there. Actually became a hematologist, so I mostly see patients with hematologic malignancies. But through that training, realized that a lot of the tests we have in hematology to really track the disease non-invasively without imaging tests, being able to do a biopsy from the blood. So basically doing a blood sample like a CBC to see if the hematologic malignancy is progressing or regressing or coming back, was something that we took for granted in malignant hematology. It was not something that we have for solid tumors. And I was actually fortunate enough to do some research on a novel liquid biopsy technology during my training. And when I was approached by Natera to come on and help lead the clinical program to develop our liquid biopsy assay, I really took that as an opportunity to join the company and really be part of this mission that, we're developing one of the first non-invasive molecular tests to really be able to monitor the disease as it's either responding to therapy, progressing despite therapy, and also detecting disease recurring much earlier than imaging. And we'll definitely spend some time kind of talking about the test and some of the implications to care for patients with solid malignancies.
Joanne, you want to say something?
Well, most of you know me. I'm Joanne Berridge, and I'm up here tonight because I have been in the trial that Dr. Billings and Dr. Aleshin are going to present to you tonight. And they told me my only role is to correct them if they get something wrong about my timeline of scans.
So far, I'm sure,
My family told more of my history than I anticipated to. But I will just bring you through the first year, because when I started the trial, it was at the beginning of the second year, my second year on Tarceva. So I will go through my little diagnosis story, which is one of the ones that I coughed for a year, being diagnosed as postnasal drip, allergies, acid reflux, and finally circling back probably at least the third time to my primary physician. She did a chest x-ray, and I was already stage 4, metastasized to bone and 1 adrenal gland. And the tumor was about 5 centimeters. The genomic testing did show that it was EGFR exon 19, so I was immediately put on. And that whole month that it took for all of that diagnosis was the worst nightmare time, really. And some of you have alluded to that in the past, so I thought I would reiterate that. That is an awful period of time when you're waiting for the test results and so forth. Anyway, so I was put on Tarceva. It worked beautifully. Everything shrunk amazingly within the first couple of months. And at the time I came into this trial, I had been on Tarceva for a year. And I was on Tarceva for the first year that I was in the trial too. And then they will take you from there.
So can I go?
Yeah, I want to jump in. I just wanted to remind everybody to remember to ask questions throughout. We provide this type of information for you, and we want you to be able to get the most out of it. So don't hesitate to grab your mic if you have a question. Anybody online, shoot one to Michelle or Jen, and I think David and Amy are online too. So.
And if you don't have a mic, just raise your hand up and we'll get one too.
So everyone who's working on this at Natera, and I bet everyone in this room and
people listening. We all hope that we can prevent new cancers, other cancers in our family, in the families of the people who are in this room. But we also hope that we can cure the disease once it's present. And what we're going to tell you about today is about a research assay, a research test, which will, in about a month, be available as a clinical test. And over time, we'll likely take it to the FDA and have it become a regulated test, which is a new way to detect the presence of disease once it's been diagnosed. We call it molecular residual disease, MRD. Sometimes that's in the literature, you'll see that used, and it'll actually be minimal residual disease. It's really, it was developed as a way to assess after an intervention, after a treatment, what was left, and was there any evidence of disease left. The same test applied consecutively over time can help you track, and we'll show you evidence from Joanne, the recurrence of a cancer that's already been diagnosed, or can potentially also track response to treatment, whether that treatment is working, whether it's slowing down in its effectiveness, or whether in fact it's not working at all. And we think our contribution to the hope is that we think that the availability of this test and its remarkable properties will really significantly add to the management and hopefully to curing more patients with the armamentarium of drugs and surgery that are available, and radiation that are available for lung cancer patients, and in fact actually for lots of other cancer survivors. So before Alex launches into sort of a description of the test, I just thought I'd prick you a little bit by saying, how do you define a cure in someone who has non-small cell lung cancer, or actually any cancer? And there's no real easy definition. Once you've had it, you're changed. But how does one define it? Well, one way is let's say you have surgery and everything is withdrawn, everything is, you have all the cancer is taken out with the surgical specimens, and you have clean margins. That's what the surgeons like to talk about, margins. And so that's one way to know that you're on the way to hopefully a cure. Another is there evidence either at the time of the diagnosis or after the treatment that there's spread? And that spread could be assessed clinically. You can maybe have a lump somewhere or a new symptom, a physical exam finding, something that suggests that you have a tumor somewhere else in your body, or an abnormal routine blood test. You're anemic, or something else is wrong. More commonly, we use imaging, and that could be PET scans, it could be CT scans, it can be all sorts of other kinds of imaging, which we do to assess you before treatment, to assess you after treatment, and to see whether there's disease remaining and whether that disease is getting bigger or staying the same or even going away. Sometimes, in some cancers, there are biomarkers that can be used, not so much in non-small cell lung cancer, but some. And then we also use these concepts like 5-year progression, 5-year overall survival to evaluate the treatments, right? How long do people live how long do they survive after a treatment? Is it 5 years? How long do they have progression-free survival? And, how do they measure that? Those are progression, which is usually an imaging or clinical assessment. Overall survival is usually whether you're still alive in 5 years or not. And then there are these intermediate criteria, which are a set of either imaging findings or other kinds of assessments which allow one to say that a treatment is beneficial or not. and is very important, by the way, in the clinical trial process. I think all of these are components of how we think about a cure in lung cancer, but really a cure is you or your loved ones feeling like the disease is controlled and gone. And we've developed a test which will I think move the field closer and closer to a day when you can feel more secure that your disease is gone, when it is gone, and when it's not gone, it can be a better target for the treatments that are available. And with that, I'll turn it over to my colleague.
Great. I think we actually have a few slides prepared, if we can pull those up. So while we're pulling those up, I think it's important to really distinguish our test from some other liquid biopsy tests you might have heard about. Oh, next slide. So when we all think about liquid biopsy, I think we frequently think about a blood-based test to really look for actionable or targetable mutations. For example, looking for an EGFR mutation when there's not enough tissue. Or for a patient, for example, on Tarceva who may be progressing, finding a T790M mutation to possibly consider the next line therapy, which would be Tagrisso. So I think pretty much everyone probably is familiar with such tests. But really, what those tests are good at, which is identifying mutations, they're really not as good for actually tracking what's happening with the cancer over time. And I think a big problem that most of us are familiar with is what to do about scans. And I think we always have anxiety when there's time to do a scan, and sometimes the scans are just difficult to interpret. So I think, just with a show of hands, how many times have you been in an oncologist's office and you've had a hard time really figuring out with the oncologist what really the scan shows? Is there a little nodule in the liver? Is that cancer or not? Has the cancer really grown and gotten bigger, or has it shrunk? So just with a show of hands, how many times have you had issues kind of really figuring out what the scan is showing, right? So I think all of us have that problem, and I think really we need a better solution. So I think while imaging is great, it has some limitations. We know that cancer can be very small, smaller than imaging can actually be able to pick it up. And sometimes imaging cannot be very representative as actually what's going on with cancer. So I think for patients on immune therapy here, you might have heard of a phenomenon called pseudo progression, where your tumor actually increases in size initially when immune therapy is started, and then actually shrinks down. And that can be very confusing, because you can imagine that if the oncologist misinterprets that increase in size in the tumor as progression and stops the immune therapy, that could be a bad thing. And it turns out that the pseudoprogression is actually occurring because the immune system in our body is attacking the tumor, and the tumor is actually growing in size because it's dying from the immune system attacking it, and not because the tumor is actually progressing. So at Natera, what we really focus on is developing a new liquid biopsy test to do what we call molecular tracking of the tumor. And that's basically providing a blood-based number that can be tracked over time to tell you if the cancer is getting larger, if it's getting smaller, and for many patients who may be in remission, also tell us if the cancer may be coming back. And we will show some data that we can now frequently catch cancer that's coming back months, in some instances over a year, before the cancer comes back on a scan. And that really opens some new therapeutic possibilities for either catching the cancer earlier, when it's coming back it's still a manageable or curable stage, or in the future, through clinical trials with some of our pharmaceutical partners, actually considering treating the cancer that's coming back before it comes back clinically and is causing symptoms and may be hard or impossible to cure at that stage. So next slide. Oh, the slide is good. So I'm a hematologist. So for many hematological cancers, there are great blood-based biomarkers that we track over time. So things like BCR-ABL in CML is a marker that through simple blood tests we can track throughout the course of a patient's treatment and see if the cancer is getting smaller, if it's getting bigger, if it's coming back. For many solid tumors, such biomarkers do not exist, and that's why we really have to rely on imaging and other clinical methods to assess if the cancer is responding, not responding, or for example, if it's coming back in a patient that's been treated with curative intent. There are some cancers that are solid tumors that have such good biomarkers, for example, prostate cancer. So in prostate cancer, there's something called PSA. And if you see how many patients are treated with prostate cancer, there's a lot of focus on what the PSA number is doing. So sure, imaging is still used in prostate cancer, but really, because there's such a powerful blood-based biomarker, the PSA can be checked much more frequently than imaging. So you don't have to wait months for a scan. You can check it every month or every few months to get a really good granular picture about what's happening to the cancer with treatment, or for a survivor to make sure that the cancer is not coming back. And really our goal at Natera is to create a PSA for every cancer, including non-small cell lung cancer, and really kind of to empower both the patient and physician to more accurately track their cancer, to both detect recurrence early for patients that are treated with a curative intent, and for patients with metastatic disease to really better understand treatment response or progression on treatment earlier than you would with imaging-based assessment. Next slide.
I'm just going to add here that another potential is to not treat people who don't need treatment. There are people who surgery cures them, other reasons that they're cured. They have when the test is very low or at zero, you're not in need of treatment. Many people are not in need of treatment at that point. So avoiding unnecessary treatment.
Perfect. Great. So I think this is just...
Question?
Yeah.
Can we grab the mic? Sorry.
Here's one, Katie.
Okay, I had a question about liquid biopsy in particular. I was wondering whether or not liquid biopsy had the potential to detect pseudoprogression. Basically, can it tell if a tumor is actually growing bigger, or if it's caused by the pseudoprogressive effect?
So that's a great question. So I think we touched on this briefly already. So for folks who may not be familiar, pseudoprogression is the phenomenon when the tumor gets larger initially when patients start immune therapy and actually then shrinks down. This is actually something great to happen. It usually means the patient will respond well to immune therapy, but if someone's not careful, may lead to premature discontinuation of immune therapy. Because of that, right now, there's really not a great imaging-based test to know if somebody's pseudoprogressing or not. So many oncologists, what they'll do is when they see a tumor getting bigger in immune therapy, they'll just wait. They'll repeat a scan. And that can be problematic because, again, if it's true progression, waiting and not switching therapy may cause the cancer to spread even more, may cause symptoms, may lead to things like pleural effusion or further metastases that may be hard to treat. But again, identifying pseudoprogression is important because if you treat the patient longer, eventually the tumor will shrink. And yes, liquid biopsies are possibly a very good kind of solution for this problem because as shown here on this slide, what liquid biopsies are doing, especially our method, is detecting tumor-derived DNA. So we know as that tumors grow and divide, some of their DNA basically leaks out into our bloodstream. And by identifying that DNA and quantifying it, we can tell, for example, if the ctDNA goes down while an imaging the tumor gets bigger, that's likely pseudoprogression because the only reason you have less tumor DNA in your blood is that you have less tumor in your body. While at the same time, if the tumor is getting larger and there's more tumor DNA in the blood, that's likely true progression, right? Because that really signifies there's now more cancer cells in our body. Does that answer your question?
Yes, but I also wanted to ask a question about tumor-derived DNA, if that's okay.
Sure.
So tumor-derived DNA, this comes from the tumor cells in question. Is this caused due to destruction of the cell, like apoptosis, or how does it enter the bloodstream? And another thing is because each cancer is different, even in the same patient, you've got multiple different types of cancers. So obviously the tumor-derived DNA strands are not going to be the same even like on a patient-to-patient basis. So how do you determine, whether a DNA strand is cancerous or not?
That's a good question. So the methods by which tumor DNA gets into our bloodstream is, like you said, through apoptosis, which is programmed cell death. Also through a process called necrosis, when usually cells don't get enough oxygen, when they're dividing too fast. They can also release DNA into our bloodstream, as shown on this slide. The problem is DNA looks like DNA. It's really hard to identify tumor-derived DNA in the bloodstream. It's almost like identifying a needle in a haystack. And really the way we're able to do it is by looking at tumor mutations that are different than our normal cells' DNA. So by knowing which mutations a tumor has, we can then design a test to really look for those mutations or those little needles in a haystack in our blood to basically determine if they're present or absent. And that's really how we identify and quantify the tumor-derived DNA in the bloodstream.
So we've had, before we've had reports where liquid biopsy has come back and said there was insufficient tumor burden. Is that the right words? Is this a problem that you also face with your test, or different?
So that's a great question. Yeah. So liquid biopsies traditionally, and I think all of us here, if you're familiar with liquid biopsy, you've traditionally thought of them as a way to find mutations that may be actionable or may signal a resistance to the therapy. We're very different. Again, we're not using that to identify an EGFR mutation in the blood. Our test is really meant for patients who have already been diagnosed with cancer, and it's really used to track the amount of that cancer in the blood. So because of that, really there's not a certain amount of tumor DNA that we need to identify to be able to track it, right? A common result from our test is 0. For many survivors who are may be using our test in the future to make sure they are still in remission, the result may be no tumor-derived DNA in their blood. So next slide.
Next.
Next.
It's coming.
Okay.
There we go.
Great. So again, I think we're really going to spend the remainder of kind of the time we have together talking about monitoring. So I think in this case, you can see a patient with a mutation, and you can see that this mutation is tracked over time. And initially, the patient has a lot of tumor DNA in their blood, but then after some kind of therapy, you can see that the tumor DNA level drops. And this is just like on imaging, seeing a tumor shrink. But here, there's a lot of more power with tumor-derived DNA, in that frequently we can detect much lower levels of it than, for example, you would be able to detect with imaging alone. And because of that, frequently you can detect tumor DNA in the blood that either increases signifying disease progression or is detected for the first time after curative surgery to really suggest relapse much earlier than you would see on imaging. So in this example, you can see a patient basically has initially a ctDNA decrease, but after surgery, it starts trending up. And this precedes, for example, clinical relapse by, in this case, 13 months. And really that starts bringing up the question, if we can detect cancer coming back sometimes a year earlier, is that an opportunity for us to intervene earlier as well? Be that doing more aggressive surveillance to identify cancer when there's just one spot of it, for example, that can still be treated? Or for the first time, can we actually start thinking about treating cancer when it's coming back molecularly instead of having to wait for it to come back clinically, and possibly actually prevent some of these cancers from coming back that are otherwise destined to come back? So really, these are some of the questions that for the first time, using a test like ours, we can start to explore.
I think there's an online question, Michelle.
Yeah. So the Signatera assay customizes the assay to the patient's mutation, right? Will it detect patients who develop new mutations that were not included in the panel or synchronous primaries?
Right. So that's a very insightful question. Yeah. So I think the question is saying that, again, we're basically tracking known tumor mutations. And by really knowing what we're looking for, that's how we can make the test very, very sensitive and specific. Because I think the worst thing that could possibly happen with a test like this is that we detect tumor DNA and it's a false positive, right? So think, you may be in remission for 4 or 5 years and your oncologist says, well, gosh, it looks like there's tumor DNA in your blood, and it turns out to be a false positive or a wrong result. To avoid that, we really have to make sure our test is extremely specific. So if we show that there's tumor DNA, that's a result you can believe. And to do that, we really track tumor-derived mutations or mutations that we know are present in your tumor. And to make our test really as sensitive and specific as it is, we actually derive a new test or a unique test for each patient's tumor. So I think the online question was, well, with a test like this, can we identify a new mutation that was not present in the initial tumor? And the answer is no. Because again, we really are focused on following what's there. And for new mutations, our test would not work. But I think really we foresee our test being used for identifying progression. And if you're seeing progression, only at that point send a test to actually look for new mutations. Frequently right now, we don't know when to send the test to see if somebody has a T790M mutation. Sometimes we have to guess. Maybe the imaging shows possible progression, but we're not completely sure. We'll send that T790M test. And there's anxiety and possible costs associated with that. We really see that the future would be where you'd see the increase in ctDNA on a test like ours, and then you would reflex to a test that look for example, a possible resistance mutation.
So just to add to what Alexey said, when we personalize your specific test, we choose, in the current version, 16 mutations which are unique and present in your specific tumor that we have a sample of. Usually we have that sample because you've had it operated on or you've had a biopsy. And we we find the 16 best mutations that we think will be stable and not change and become less sensitive over time, and create this personalized assay for you. And then we apply it to your blood later on. And if we find 2 signals, 2 or more signals, then we call that positive and measure the amount of those signals in the blood. So it's a complicated assay. It has 16 components to it at the beginning, but those are all relevant to your specific tumor, and that's what gives it the beautiful specificity and sensitivity that we've demonstrated so far.
Ron, did you have a question? Oh, Ron needs a mic. Thanks, Fred.
That was a good clarification that you're detecting it based on the customization. And I think then that derives the whole question, like, it sounds expensive as opposed to a generic. It sounds more expensive than if you had a generic mutation panel assay that looks at the hundreds of known potential cancer mutations. Because we know that everybody has cancer DNA in their blood of some sort. It's just how our body works, right? Everyone has cancer and our immune cells are fighting it. Is when our immune cells fail that we get something that breaks out. So the question then is like, how if you're customizing it, how can this be cost effective? Right. And secondly, you haven't talked yet about how fast can this be? Because most of us, when we do a genetic mutation for a genetic assay that looks at the markers, we're waiting. And so talk a little bit about the speed of this and the cost of this.
Right. So I think your first question is extremely insightful. We all do have, not necessarily tumor DNA in our blood, but we all have clonal DNA in our blood. So this is DNA that can look like tumor DNA. And it turns out things like premalignant skin lesions, things like endometriosis, or even the accumulations of mutations as we age, something called CHIP, or clonal hematopoiesis of indeterminate potential. All of these processes that are fairly normal and are going to be present in a large number of patients, healthy or affected by cancer, like lung cancer, are going to have these processes going on. So if you are looking at a generic set of mutations in the blood to basically identify presence or absence of DNA, you are frequently going to be fooled by these other processes. And that's going to cause a lot of these false positives and also just poor performance of a test. And to avoid that, to really be able to provide a test that can be believed and can be monitored and the results can be tracked, we have to do this personalization. So I don't know how many of you have had a liquid biopsy done through a test like Garden or Foundation, but frequently, you'll see the EGFR mutation, for example, that your doctor is looking for, and then like 5 other mutations, right? And those other mutations are present at very low levels, and you ask your doctor, well, what do some of these mutations mean? And the doctor may say, well, I don't know, and maybe these are false positives. They're really low levels. We don't know what these mutations signify. And frequently, at very low levels, these mutations are false positives. And because of that, while liquid biopsy tests that are on the market today are really good for identifying actionable mutations to kind of better select therapy, they're really not great for monitoring the treatment response and detecting early recurrence. So while the test is a little bit more expensive because of this, once it's designed, the test is fixed and it's not needed to be redesigned every time. So it becomes more cost effective the more you do it. And because of that, for the first time, we foresee a future where you can get a tumor monitoring test done as frequently as you would like. And that could be, for example, if you have a backache and you're a 4-year cancer survivor, is that backache my cancer coming back, right? I think frequently we worry. And many times that triggers a CT scan, which has radiation cost, some time away from work. But if there's a biopsy test, liquid biopsy test like ours, and it's negative, well, gosh, that backache is likely just a backache. And, this is something you can watch and not necessarily do a CT scan. So that's kind of where we see the test going. But yes, I think the cost is definitely an issue, and I think all innovation is associated with cost until we kind of figure out how to offset some of that cost.
So I would say, I would add only that we're lucky. We use next-gen sequencing as part of the assay, and the cost of running a next-gen sequencer has been dropping dramatically. It'll reach a point where it doesn't drop anymore, but it has been dropping, and that works to our advantage. The other thing I would say is that PET scans and MRIs and CT scans, which are and when we talk about Joanne's case, which were used in Joanne's case to measure recurrence or residual disease in Joanne, those are expensive too. In fact, as Alexey said, once we have our assay established, once the original set of mutations have been identified, then our assay over time actually isn't very expensive. Maybe not as expensive as the PET scan that you get every 3 months or every 6 months. And so I think we're going to actually right-size and reduce overall the cost of care as time goes on.
Sure.
So if I understand right, and we're monitoring over time, not specifically for new mutations or mutation types, but just a personalized set of assays. So like if you have the ubiquitous TP53, then everyone's got that, so we can monitor that. It's kind of like looking at your CA levels then over time and checking on it, because then it'll be hopefully cheap enough that we can do that routinely.
Right, so you bring up a good point. So CEA, for folks who may not know, is a tumor blood biomarker used frequently in colorectal cancer and other gastrointestinal malignancies, and it can be tracked over time. And again, when such markers exist, they frequently kind of enter clinical practice and are used for more frequent monitoring than it could be possible with imaging alone. So in a way, yes, we do foresee ourselves being an ultra-sensitive and specific CEA that's applicable to most cancers. But I will point out that CEA is notoriously a poor blood-based test that has a lot of issues with both sensitivity and specificity. So we're really trying to improve on that. And in lung cancer, currently, there is no CEA. So it's definitely kind of a completely open field to really innovate in.
You haven't talked about how fast this might turn around or what your hopes might be. And then secondly, I think this is a softball maybe, Talk about how hard it is to detect ctDNA, because it's like searching for not even a needle in a haystack, but a needle in a hayfield, and how hard that could be, and why yours is so good.
Right. So, Paul, you want to take the turnaround question?
Well, so currently the test itself, once the test is made, the turnaround time is short. Really, the long part of our assay is the sequencing of the tumor from the tumor sample that we get either at biopsy or at excision of the tumor, and then returning the sequence, running it through the bioinformatic tools that we have, and then sending off to have the assay actually created specifically for you with, as I said, the 16 targets in that assay. So that's the major time sink here. Once the assay is created, doing the PCR on the plasma of your, as you're monitoring or assessing residual disease, and sequencing the product after that, that's a short few day kind of a process. So as the test is a research test now, and Joanne, how long was it before we returned results to you?
It's been, maybe 6 weeks. It's been pretty long.
Yeah, so it's months now.
The explanation is because you're batching and...
Exactly.
It's lab research.
Right. So we're not, what I will say to you is we've done 1.5 million cell-free DNA tests in our prenatal part of our business. And we have optimized and scaled the ability to do cell-free DNA tests, I think, better than any other company in the world. So we've really driven the cost out of that, and we've really raised the quality, and in particular, we've raised the speed, so that the turnaround time for our cell-free DNA test, the prenatal cell-free DNA test, is just a few days. And that's what we're searching for with our cancer test. We're just a little earlier in the development cycle.
But initially, you need tissue.
We don't need tissue for the prenatal test.
No.
Okay, but for lung.
For the lung, you do need tissue.
Okay.
At present, we're looking at ways that maybe we could get around the tissue, but the first clinical iteration of the test will require tissue.
Okay, and that you could get the genomic profile as well at the same time.
Absolutely.
Okay.
And so we're actually, interestingly, and you're a smart lady, Bonnie. We're not only thinking about the Signatera test, which is the the molecular residual disease and monitoring test, but we'll have to do a tumor profile of the tissue, and we're thinking about making our version of that and the germline mutations that we find at that time. We're making that commercially available where Foundation or others either haven't been satisfactory or for whatever reason. And maybe we can do a bundle, we can become the one-stop shop.
One size fits all.
Exactly.
Yeah.
And is that tissue only from a biopsy, or can you get that out of, for instance, pleural effusion?
Well, that's an interesting question. Have we done pleural effusion?
That's not something we're necessarily validated to do, but there should be no issue with continued development to do from pleural effusion as long as there's enough cells. Yeah.
And that might be all you can get from a late-stage patient.
Maybe so.
At some point, yeah.
So I think that one other point is that we can design our test from any tissue, right? So if a patient, for example, had a resection 5 years ago, we can use that tissue. And there was a biopsy done for another purpose a few months ago, we can use that tissue. It really doesn't matter what the tissue is, as long as it's from the cancer, we can design to it. And while we design the test, we actually do whole exome sequencing. And just to put that in perspective, when you have your tumor sequenced, when I started practice, we'd sequence maybe 3 or 4 genes, EGFR, AL, CROS, then started doing RET. Then I think most of us now are sequencing, 100, 200 genes, because we really believe more information is better. For us to do the test, we actually sequenced 20,000 genes. So we sequenced the whole exome. And that's information that eventually we do want to make clinically available, because we do believe that the more information a patient and physician has, the better. because those extra genes may identify another clinical trial you may be eligible for. And even if it may be not relevant today, maybe 2-3 years later it would be relevant. And that's information that we derive and are able to provide as a byproduct of our test, in addition to its ability to kind of monitor the cancer over time.
And wouldn't that eliminate the need to do any more tissue testing? You could just do blood testing from that point on because you have the whole genomic profile.
Exactly.
Yeah.
Yeah.
Michelle, did you have a question online before I go back to Ron?
I did.
Yeah, sorry.
So
sorry,
if
Ron, you're next.
if someone's had several blood biopsies and they've never showed a KRAS mutation, how is your technology different? Do you think it would find KRAS in their blood?
Right. So that's a great question. So I think sometimes liquid biopsies are used to identify mutations that are usually associated with either treatment response or maybe treatment failure. So KRAS in certain instances may be associated with poor response to therapy or resistance depending on the cancer type. Again, our cancer is really not designed to identify actionable mutations or resistance mutations. It's, again, mostly designed to track the treatment response over time or detect recurrence of the cancer earlier than imaging or other clinical methods. So again, we would not recommend our test be used to identify a mutation like KRAS in a patient where that may be important to know.
Ron?
I'm thinking, but it's a dangerous thing to think. So if we're dependent upon the tissue samples that are provided, then we're also dependent on the accuracy of that tissue itself. If the tumor is heterogeneous, like we know it can be, then they grab the wrong side of the tumor, then we might miss something. Is that a fair description of maybe something that needs to work on, or is that whole genome thing sequencing going to resolve that?
I mean, again, extremely insightful question, right? So I think the reason many times your physician may do a liquid biopsy in the traditional sense of a liquid biopsy is to avoid this problem of tumor heterogeneity. You know, your biopsy may not show an EGFR mutation, but the liquid biopsy may. And that's because the EGFR mutation may be present in some cells, but not be present in other cells. But at the same time, think of the problem. You know, if the EGFR mutation is not present in some cells, those cells may start growing over time and cause your cancer to progress. If you're tracking a mutation like EGFR, you may see it going down, and while the cancer is actually progressing with another mutation like T790M. And that's really the problem of using current liquid biopsy tests over time to figure out if the cancer is responding or not responding. We avoid that problem by focusing on something called truncal or clonal mutations. And these are mutations that are present in all the cancer cells. And there's really two benefits here, because if we are tracking mutations that are present in all the cancer cells, even if a certain set of your cells are causing progression, we'll still pick that up. And because, again, we're focusing on mutations present in all cancer cells, the problem of tumor heterogeneity or the presence or absence of certain mutations in certain cells really doesn't apply. And we're able to do that because, again, we look at all the mutations and we can really cherry pick the mutations that are very early and are going to be present in all the cancer cells. And because we track 16 mutations, even if we make a mistake once or twice, we really have kind of 16 shots on goal to make sure we're right in the end. And so that's how we avoid that problem. Great question.
So I'll just add, when I was here the last time with Pinpoint, Pinpoint is a test that really depended on clearly identifying the cancer and the normal tissue in a block from, let's say, someone with lung cancer. And I hear you that you show one pathologist, you know, and he'll say there's the cancer, and you show another pathologist, and maybe they'll agree over about 50%, but maybe they'll say there's another focus of cancer there. There's a lot of argumentation between experts doing their best, but really who don't see things exactly the same. One of the nice things so far about our Signatera research assay is that to date, we really have seen that the assay performs, and the situation that you described just hasn't occurred. We really haven't, with a rare
we've done hundreds, maybe even 1,000 now, and we really haven't seen that be a problem. So, we have empiric data that the way we're choosing the mutations and their expression in the blood or their availability in the blood is in fact tracking the main component of the tumor.
Yeah, go ahead.
I had a quick question about liquid biopsy.
Are you a patient or a student or?
Oh, okay. Sorry,
are you?
I didn't introduce myself earlier because I ended up attending late. Okay, I'll go ahead and introduce myself. I'm Steven. I am a student at SJSU, San Jose State University, and I am part of a patient advocacy group for this semester. And so I am here so that I could hopefully learn a bit more about the lives of patients with lung cancer and see what I can do to help out in the field.
Well, good for you. Okay, well, welcome.
Thank you so much. And as for my question, I wanted to ask a little more about the liquid biopsy question. So I noticed that liquid biopsy relies on having a tissue sample present and has a side effect of having a large risk of false positives. Would you say that this would be a sort of a severe limitation of the technique, because it seems that it's not as effective for new patients as for patients that are continually being monitored? Or would you say that the focus on monitoring on liquid biopsy would be a better path? Like, would you rather delegate this to monitoring a progressing cancer case and rather save, diagnosing for an actual physical biopsy?
No, you already said that. It's not
You're
for
mixing
diagnosis.
things up a little bit.
Yeah, okay, here, let me
let's
phrase
see if
that
we,
better.
No, you don't have to
Phrase that
rephrase it. Let's see if we can clear it up for you.
Yeah. So would you say that it's a severe limitation that the liquid biopsy needs a physical tissue sample? Is that a severe limitation
Not
of the
for
technique?
original diagnosis.
So I don't think that's a limitation. Currently, for cancer to be diagnosed, there needs to be a histological diagnosis made. So cancer is diagnosed through tissue, through a biopsy, and we rely on some of that tissue to design the test. So for most patients, the tissue will be available. So I don't think that's a limitation. I think it's really part of the strength of the test that we are able to utilize the tissue to make the test more sensitive and more specific.
Right. It just depends that the tissue sample in particular is actually reliable, like it wasn't affected by tumor heterogeneity or.
Well, that was his question.
Yes, yeah, that was the previous question.
Okay, thank you so much.
Carolina.
I just have a question of clarification. You're saying this word assay?
What do I mean by assay?
Assay, yeah. How do you spell that?
A-S-S-A-Y, assay, and it just means a test.
Okay, I just wanted to write it
It's
down.
just
I've been writing it down.
I'm sorry if I speak
of
in scientific lingo, mumbo jumbo. I
It's
appreciate.
like-
I fall into that. My wife hates
Yeah.
it. What
And
can I
all the
say?
acronyms and
Assaying
everything are
or-
meant to confuse you.
No, but it's good because in the future, if we hear that,
No, of
it'll
course.
be familiar. I just wasn't sure. Just so
An
I
assay
spelled
is a method,
assay,
is a test.
A-S-S-A-Y.
They're all sort of synonyms.
Okay, thank you.
Great. So if we can maybe go to the next
Go back
slide.
to your slide.
Yep. Because I want to make sure we have time for Joanne's case. So next, please. So I think sometimes going just through a hypothetical case can be helpful. So imagine this is a patient with newly diagnosed early stage lung cancer, so stage 1 to 3. And really the goal here is to eradicate the cancer and prevent it from coming back. Next slide. So this is a real example from one of our prior TracerRx publications that came out in 2017 and was actually featured on the cover of Nature. But you can see in this case that the patient undergoes surgery, and after surgery, the ctDNA levels drop. And they actually drop, but they're still detectable. So the second time point, you can see there's still detectable tumor DNA in the blood. So even though this patient has undergone surgery, the margins are negative, the surgeon says, I think we got it all, we can still detect traces of tumor in the bloodstream. And I think some patients sometimes struggle with, do we need adjuvant chemotherapy after surgery, right? Do we need to give chemotherapy to really eradicate that tumor? So for stage 1A cancer, we typically do not give adjuvant chemotherapy. For stage 1B, sometimes it's tricky. For stage 2A, we should give it, but sometimes somebody's sick, maybe they don't want it. So how can we better decide who really needs chemotherapy after surgery and who can kind of get away with just observation? So in this case, if we're detecting traces of tumor still in the blood after surgery, well, gosh, I think this patient definitely needs more treatment, right? We know that tumor left in the body without additional therapy likely will grow and cause a recurrence. So in this case, this patient was treated with CTX, that's chemotherapy, and RTX, which is radiotherapy. And we can see that the tumor DNA responded. It went to 0. So even though you could not see tumor in this patient, right, the tumor was completely taken out with surgery, you can actually see how the traces of tumor are eliminated with adjuvant chemotherapy. And with long-term follow-up, you can see the tumor DNA remains at 0, and this patient continues to be in remission in this study. Question?
Thanks, Katie.
I'm going back quite a ways to my mother. They didn't stage it in 75, but it was found early. It came back in 2.5 years. She went 20 years with nothing. Would your test have been able to tell that she was going to still get cancer 20 years later?
Or could you tell if Sally and Evie, who, had surgery, Evie just recently had surgery, and Sally, is there a way for them to see now if they have something?
And to Sally's point, though, is it lifetime monitoring? I mean, whatever. I mean,
Right.
how long?
Right. She's getting all those, well, they're both getting the CTs.
Right. So I think the test could be used in all those situations, yes. For patients who are cancer survivors, it can be ordered to see if there's tumor DNA in the blood and if it's coming back. And, it possibly could find it coming back much earlier than imaging and provide a window of intervention. The problem, I'll be completely honest, is today there is not much intervention, right? I think we need more studies to figure out, if we're detecting cancer coming back earlier, can we do something about that? And I think really working with our pharmaceutical partners to figure out new strategies of what can be done is going to be important, because the problem with our tests right now is if we detect tumor DNA and nothing is done, your cancer is going to come back. Right. And I think
come back 20 years later.
Could.
It could, but
it's possible that you also get a second
Yeah.
cancer, right? We know actually primarily from young people who've had cancer, let's say as pediatric in their baby, that there's a higher frequency that they might get a second cancer. Sometimes it's a blood cancer, sometimes it's a second solid tumor, if they've had, let's say, a connective tissue tumor, various things. So their second cancers would not be detected by our assay because the assay is specific to the original tumor. But frankly, we haven't really had much experience, and we certainly haven't had experience 20 years off.
Mm-hmm.
So we can speculate about it. But
it is something that's growing, out there that, people are having.
Second tumors?
Yeah.
Yeah.
Well, second tumor and really do need chemotherapy and radiation after surgery.
Absolutely.
Yeah, it's a big part of the population of lung cancer.
Yep.
Exactly.
So this can do a lot of good.
Absolutely.
I don't know if I'm allowed to ask this, but is this really across all kinds of cancer?
It is. We'll show you a picture in a moment.
You're allowed to ask whatever you want, Barb.
Right. We'll show you a picture of several other kinds of tumors.
We'll throw something at you if it's a stupid question.
So if we can go to the next slide. So again, in this scenario, again, the ctDNA goes to 0, the tumor DNA goes to 0, stays at 0, and this patient does not have a relapse. Next slide. But we can imagine a different scenario where, again, the same kind of initial response to treatment after surgery, but then soon after, during the recurrence monitoring, we see that tumor DNA becomes detectable. And this can precede clinical recurrence by quite a bit. Not 20 years, but usually in the order of months to sometimes over a year. And again, that provides a window of possibly trying to identify a local regionally advanced recurrence that can still be treated with curative intent. And in the future, we hope that this could be an earlier time to intervene, because we know frequently when cancer comes back, it's no longer curable. It's now going to be advanced or metastatic. So identifying it at molecular stages of recurrence with proper studies, possibly that would be the new time to intervene and prevent some of these cancers from coming back and becoming incurable.
And at that point, when you find it that early circulating in the blood, I mean, you're talking about some sort of systemic therapy, right? I mean, it's not.
Yes.
Exactly. Exactly. So,
I just want to follow up on Sally's question. So, for example, I'm no evidence of disease. Everything looks great. But in the best of all situations, the blood test, I would be going for the blood test so that you would be able to pick up if indeed I still had the cancer.
Right.
Or if it was coming back. Exactly.
Right.
If it's coming back. Exactly.
And how often would somebody go for a test like that? Now I'm going every 6 months for a CT scan. How often would I go for the blood test?
Yeah.
Or you don't know, maybe?
So I think with every new test, this is still something we're researching, right? And currently the test is research use only. It's going to be available clinically in the next month or two. So we don't have a right answer. We believe for lung cancer, usually every 3 months in the beginning for the first year or two, and then after that, doing every 6 months to really kind of correlate with current imaging guidelines as well as your oncologist visits. It's going to be where I think most people start. And then we're going to do additional studies to figure out if either more frequent sampling or less frequent sampling is really kind of the optimal schedule. And usually that takes a little time to kind of really optimize. But again, I think our hope for the future is, again, not to replace imaging, but possibly decrease imaging. So instead of going for a CT scan every 6 months, maybe every year. And we know that CT scans are not harmless. I think that the second, cancer coming back in 20 years, sometimes those cancers are actually are from the imaging that's being done and exposing folks to radiation during the recurrence monitoring setting.
Right.
So if we can minimize the need for imaging, I think that's a big win as well for us.
And would the idea be that you would go to your primary care physician, and the blood draw would be done by that individual, and then so it would be kind of standard of care?
That's the hope. I think initially it would still be an oncologist that would be involved to interpret the results, but I think the further out you get, it could be even your primary care doctor. And I mean, our hope is to make it even as simple as having somebody maybe even come to your house through a mobile phlebotomy network and actually draw a blood sample, so you don't even need to go to the office. Because I think the more we can kind of dissociate some of the tests that remind survivors of their cancer, like imaging, the better. If it's something like a blood test that just comes back negative, I think it's easier than the imaging where there's uncertainty, where there's little nodules. Nobody knows if that nodule is cancer or not. Really, I think that could be the power of a test like ours with proper studies to really kind of improve on some of the uncertainties associated with imaging today.
Are you going to let people know tonight if they can be involved in your clinical trial, or when this becomes a clinical opportunity where that will be?
Mm-hmm.
I mean, I think, we can definitely discuss. I think every patient's situation is unique, and I think if people are interested in the friends and family prospective banking protocol, I think it's something we can then definitely discuss after this meeting. Again, the test really is not used for clinical decision making right now. I think it would be collecting your plasma for more research, for better understanding the test. And when it becomes clinically available, people on that protocol could be switched over to the clinical version of the test that then could be used for clinical decision making.
How many patients are in your trial?
That's a great question. So again, we focus on many cancers, lung cancer being one of them. The trial we're doing right now is mostly focusing on kind of improving the test, making sure there's no issues that we oversee prior to clinical launching the test. So really our goal for that trial is to be in the hundreds of patients. We've enrolled over 50 to 60 patients to date. But really the studies we've done have spanned hundreds, if not over 1,000 patients using mostly prospectively collected banked samples that were then analyzed. And these were basically patients who had plasma collected over years, kind of before treatment, during treatment, after treatment, then were analyzed with our test to basically generate some of the data to support.
These were all done at academic centers.
At academic
Yes.
Yeah.
Do you have to go through the same trial stages of a drug or of a biologic? I mean, what are the FDA requirements for you?
That's a good question, yeah. So the test for it to be available clinically is actually, can be regulated by the FDA.
Right.
But there's also something called CLIA, which is another form of regulation that many tests that actually are done today are regulated through CLIA. Initially, our tests will be CLIA approved, but our hope is actually to get it through the FDA in the not too distant future. I think maybe this is a good point to really mention that our hope is not just to kind of release this test and let patients and physicians to figure out how to use it, but really to kind of engage with partners like the Dario Foundation and other pharmaceutical companies to really do the studies, to really better figure out how the test should be done. And to that goal, we've really announced and are going to be soon enrolling patients on the first prospective study using our test and a test like it to identify patients with molecular residual disease, so disease, again, that can't be seen, to then randomize those patients between standard of care versus a more aggressive therapy. So these are basically patients who have stage 2 or 3 disease, have surgery, lung cancer patients, exactly. And then, you know, if we identify tumor DNA in their blood, the question becomes, well, is standard chemotherapy enough? I mean, maybe these patients are the ones who need more, and this study will actually be then randomizing those patients between standard of care versus standard of care plus immune therapy to see that maybe kind of doing 3 drugs instead of just 2 in the adjuvant setting, maybe that's really what's needed to help us cure more patients.
War. Go to war.
Go to war, exactly. Because again, we shouldn't forget that really the biggest problem is relapse, right? I mean, more than 50% of patients are diagnosed with possibly a curative form of lung cancer, but the relapse rates remain unacceptably high. And anything we can do to really benefit the patients who are really going to be destined to relapse with standard therapy, I think is going to be important. And, you know, our test kind of, for the first time, allows us to identify those patients and go to war for them, but also identify patients who are not likely to benefit from a more aggressive approach, and in the future actually consider de-escalating therapy in those who are not going to benefit from it.
And the CLIA lab he's talking about is like the Good Housekeeping seal of approval for research.
Right.
Right?
That's right.
I mean, I'm minimizing it.
Yes,
but
yes. I mean,
it's a seal that everybody thrives to have.
Right.
In the
exactly.
research world.
Exactly. So it's a regulated environment. Yes.
Yeah.
Yeah.
Michelle, do you have a question? No? Okay, I just wanted to check in. Ron has a question.
Sorry, I do have questions. Because there are no stupid questions,
No.
except the ones I don't ask. You're going to personalize the tests based on the patient's tumor, but at the same time you said you're going to something called trunk core clonal mutations, which are present in all cancer cells, which sounds to me like that's the agnostic diagnosis generically. So I'm not quite sure I grasp the difference here.
Right. So that's a great question. So it turns out that all of our cancers have very different mutations. There are certain mutations that are more likely to occur, like EGFR, for example, or TP53, but really no 2 cancers have the same mutation. So it's really hard to reduce a test like ours. The test just looks at a certain set of mutations. That's why we have to identify every patient's unique set of mutations, and then actually using an algorithm, say, these sets of mutations are likely to be clonal or truncal, and that's a fancy word for basically saying that all the cancer cells share these particular mutations, and then select those mutations to use for tracking purposes with our test. So I think in the interest of time, I want to really make sure we can now switch over to Joanne's story.
We have to hear Joanne's story.
Make sure we have time to focus on that.
Go to the next slide.
The next slide?
Just like it was at Cal Berkeley.
All right.
So do you want to tell your story? I mean, The answer was that you were, or the. Let me say a few words about you.
Yeah,
How
okay.
about that? And if I
We
get,
didn't rehearse this.
Right. So
we did meet.
You had symptoms in September of 2016, as I remember.
Symptoms for a year before
that. But you had a cough. You had a smoking history.
20 years, or
right,
25 years earlier.
Right. And the diagnostic tests were done in September or October? Do you remember?
The biopsy was done in September.
September.
And then the genomic test that showed the EGFR, a couple of weeks, took a couple of weeks. Right.
So you, at the time, you were staged as being stage 4.
Yes.
Because you had not only tumor in your lung, but they thought you had tumor in your bone, in your adrenals, but not in your liver or other sites.
No, and I also had an MRI. There were no brain mets. It was
brain mets.
One adrenal gland, I forget which one, and to read the scan report, every bone in my body has.
Right.
Anyway, they say.
So you were started in October of 2016 on Tarceva.
Yep.
And really for 2 years, you had a pretty good response to Tarceva.
I did.
You were feeling pretty good, and how did in 2018? What was it that began to worry you, or what was it that was the signal that things might be recurring in 2018?
Nothing worried me.
Yeah, good. Well, that's good.
I was interested in knowing sooner rather than later if there was any progression.
Right.
And as my UCSF oncologist, Dr. Blakely says, you got to stay ahead of the game.
Right.
And I'm not sure that the standard of care has that same, just comparing my PAMF oncologist with the UCSF. I don't think they have that kind of same mindset.
Right.
I'm right on,
right.
on
Yeah.
that.
Right.
Okay. So anyway, any way that I could know sooner that there might be progression was a great thing.
Right.
And I heard about
your daughter Sarah.
My daughter
clued
Sarah
you in, yeah.
clued me in that there is this test going on at Natera, and Natera has a friends and family program, so I could be a patient or whatever you call
part of our study.
Part of your study, and so my first blood draw with you was in October of 2017, which was 1 year after I'd been on Tarceva.
So we got your sample.
And my tissue was all at down at Mountain View. Dr. Krishna helped me told me how to get that. So you got my tissue. I met with Dr. Aleshin, and he got my history, and you put it all into your lab and your research. And then let's see. So that was in October of 2017. You took the first blood sample, and it was 0.37. I don't know if you have my chart.
So if we can go to the next slide, please.
Yeah, maybe my chart was.
So we can see that's the first time point.
The first time point is what, on the left?
On the left,
right. Okay. And that, I don't know what the numbers mean, but that was a 0.37.
So I'll explain. Yeah, so these are tumor molecules per milliliter. So usual standard tube of blood is around 10 milliliters. So Joanne had in that tube of blood, on average, if you take 0.37 times 10, again, that's 10 mLs of blood you usually get drawn. So she only had 3.7 pieces of tumor DNA in that tube of blood at that time. And again, to put that in perspective, that's a pretty low number. So again, there is definitely cancer in her body, and we know Joanne has stage 4 disease, so Tarceva is really controlling the disease, it's not really getting rid of it, but that's a pretty low number in our experience. It means really there's very little cancer in the body at that time.
So then, you didn't have your scan. Did you have a scan between 2016, and when you enrolled in with us.
Oh yeah, I had stable scans.
Right,
every
so your scans had been stable.
3 months, 4 months,
Right.
5 months, yeah.
Right, so even though your scans were stable, the first time we measured, we found something.
We found something, right.
But it was, as Alex said, it was low.
It was low.
And so then you had another stable scan after October of 17 and before April of 18.
Right.
You had another scan. Didn't show much progression on that either.
None.
But
none.
Was she still on Tarceva?
She's on Tarceva.
Yeah, I was on Tarceva for 2 years.
Right.
Okay.
And as you can see on the second, which was in April of 18.
Right.
It's up a little. What was the?
And the scan was normal.
And the scan was normal,
That same
but
April,
in fact,
the scan was
your ctDNA level was rising.
It was rising.
Gradually, but rising.
The scan showed stable.
Stable. So this is the first incidence of our research assay showing a discordance with
the scan.
The scan.
Yeah.
And Joanne has introduced the concept of scanxiety to me, and I'm now, it's now a permanent part of my vocabulary.
Yeah.
But I can imagine that as we show more and more incidents of where scans are less sensitive than our assay, people are going to have a lot of, but it won't be part of standard of care yet, I'm afraid.
Right.
There'll be a lot of scanxiety out there.
Oh, absolutely.
But because this was research in the labs, batched and so forth, I didn't know about the increase in the tumor DNA until well after that scan.
Right.
Had I known at the time of that scan or before that scan, I would have thrown up the red flag, you know, let's talk about or do further research or further genomic testing, whatever we need to do to find out what's going on here. But
so in August of
2018,
you had another scan.
Right. And that one showed some little nodules that nobody knew what they were. So that was a CT scan. So the doctor ordered a PET scan, and it showed more metabolic activity, but still nobody knew what we should do about this. But at the same time, the new tumor DNA, and these did come in at about the same time, showed a spike.
Right, so that's the last time point on that chart.
On that chart. So Dr. Blakely ordered a Guardant test immediately.
Okay.
And it did show T790, and that's when I changed it to Tagrisso.
Right.
Okay, and now show them the next slide.
Please.
And that was 2 months on
after the
Tagrisso, down to 0.
Boom. Yeah.
Boom.
Yep.
And I've had one draw since in February, and don't have that result yet. At the beginning of this month.
Have you had a scan since the one that showed the PET scan?
Oh yes, I had a scan. Wait a minute, Tagrisso, September. The scan at the time of the chart dropped.
Yes.
Did show stable, and then I had another scan in January that showed stable.
So what you can see here is that our test was coming up before the scans really progressed, and that the scan restabilized, became more abnormal at the time, at the peak of our assay. And then when, after she was changed to the Tagrisso, both the scan stabilized and our test has dropped back down to a very low level, actually lower than she was when she was originally diagnosed.
Well, that says a lot.
Which is good news.
That's right. That says a lot.
So
and I'm waiting for the results of the February 4th draw and hope it's still on 0.
Tell them you're waiting at home. They're going to come and get it.
They do. They do. They send a phlebotomist.
That's great.
Yeah, actually, on that topic of phlebotomy, we have a network of over 1,000 phlebotomists that we developed for our prenatal test. And you know, we also have a transplant test that I told you about. And sometimes we have to send these people off into the wilds to draw people who've had kidney transplants and so forth. So we're prepared to provide that for cancer patients as well.
Yeah. I've had the same one every time. Her name is Nancy. And she's very interested in what the study's doing. And
that's great. That's great. Well, this is awesome.
And Joanne, could you read just the numbers, the values from the ctDNA assay? Because again, I think the important thing is that this is almost happening over a year. Joanne's imaging is stable. Maybe at the end there's possible progression, but again, but again, you're unsure. But this is what the numbers are actually doing.
Yeah, well, 0.37 was the one at the 1 year stage.
Yeah.
Okay, and then that was in October of 2017. April 2018, it was 2.64, and then August 2018, 112.14.
So quite a dramatic.
And it was at the 112.14 stage that anything started to show up on the CT scan.
So the imaging is stable, but the amount of tumor DNA has gone up over 300 times in the blood, you know?
Yeah. How does this compare to Pinpoint?
Well, Pinpoint was, remember, Pinpoint was primarily a tissue diagnosis, right? It was really about classifying with a series of expression genes whether something should be treated or not treated in early stage lung cancer. This is actually, this is about residual disease and monitoring in really the whole range of cancers across. If we go to the next slide, actually, let me just see what the next slide shows. Well, this is basically what we just said, right? I mean, I don't know. Is there another point that you want to make from this slide, Alex? Or
I mean, I think just in the interest of time, we won't go very deeply, but again, I think this kind of goes to the point that could we use Signatera after surgery with proper studies to really select the patients who are going to be most likely to benefit from therapy and actually give them more therapy and feel good about giving them more therapy, because we know we're really kind of burning that cancer into the ground, while patients who likely have already benefited from surgery and may be cured with surgery alone, like we know many stage 1 patients are, possibly sparing those patients therapy and possibly sparing some stage 2 patients or de-escalating therapy and really kind of giving the right adjuvant therapy to the right patient, right? Just like we think of the...
But go to the next slide. So this is, someone asked before, does the test really work? This is exactly the same test that we offer lung cancer patients, a customized molecular residual disease and monitoring test. But these are studies. The bottom one is the study that Alex mentioned from the Nature publication that we did with Dr. Swanton in Europe. But we've done it in colon cancer, we've done it in bladder cancer, we've now done it in breast cancer. We've got smidgens of other cancers where, and the test is performing. It's amazing. I mean, one of the things that I sometimes send these are called Kaplan-Meier curves, send them to people, and the thing that's so amazing is that they all look almost exactly the same, which is if you have ctDNA, if you have a DNA detected by our assay in your blood after your diagnosis, you're going to relapse. It's basically 100%.
Unless you get treated.
Unless you get properly treated, of
So
course.
these are patients who basically were observed, so without treatment, positive result by Signatera is associated with a relapse close to 100%.
Right. While if you don't have ctDNA detected by our assay, your chances of relapse are very small. It's not zero. You can see there's little ditzels. There's occasionally a patient who will relapse, but it's very, very small. So that helps us make those decisions about who should get aggressively treated and who not from that kind of data. It's amazing. I mean, these are called hazard curves. You see HR there. These are numbers kind of unheard of in clinical research. So it's exciting.
And I think the last point I do want to mention, because I know we're running short on time and I want to leave maybe a few more minutes for questions. Is that we also are thinking about using our test for patients who've had an exceptional response to therapy with stage 4 disease to really figure out which patients may be able to come off their treatment. And we know that for the first time, possibly some patients with stage 4 lung cancer, especially with immune therapy, may be cured with that therapy. But right now, there's really not a good test to know if somebody is cured or not. And because of that, many patients remain on immune therapy sometimes for years. sometimes 5, 10 years. And the question becomes, is it sometimes safe to stop?
Or they keep getting CT scans until they die.
They're getting CT scans, they're getting treatment. The treatment can have toxicity. You know, there could be side effects from prolonged immune therapy. And the question becomes, can you identify patients who have no tumor DNA in their blood with stage 4 disease, and could you do a treatment holiday or consider stopping that therapy?
And that would be relevant to targeted therapies as well as maintenance chemo, right?
Right.
Not just
and
IO.
On that note, Dr. Blakely did point out when he saw that mine went to 0, he said, we still see the tumor there. He said, but it could be totally dead. It could be totally scar tissue. We can't tell that.
Right. Exactly.
So I was recently at a meeting with the physician who's the overall scientist in charge of Merck, you know, the very large drug company. And he said that the single biggest, you know, and they've been obviously a leader in the introduction of immunotherapy for the treatment of cancer. He says the single issue that they don't know the answer to is how long they should keep people on immunotherapy. They say routinely people are kept on for 2 years, but really we don't know if that's too short or too long. And
they're just now starting to figure that out.
He's full speed ahead trying to figure that out.
So I wanted to leave a little bit of time for housekeeping and for Miss Sally has an announcement that she would like to make. If you want to do that now before I thank everybody and close out the meeting.
Having a baby. Well, I just wanted to let everybody know that we had a really successful Lungfish Society wine tasting, thanks to K&L Wine Merchants and Clyde Buffa that provided all the wine. We had it here in the living room, and we're going to have more things coming up in the future. We want to make lung cancer patients and caregivers have time away from lung cancer just to have fun. So we're going to try and figure out some more fun things. And also I'm going to try and get another no-host lunch again, maybe in April. And so we'll be in touch with you. And if you don't think I have your email address, please send it to me so that I can add you to our list. And you can send it to me at sally@lungcancerfoundation.org.
And Sally, this isn't something that's just specific to local here. Could people in other parts of the world and the country put together their own groups, maybe through social media?
We'd be delighted if they did that. And I want to thank Sheila Von Driska because she was the one that got in touch with K&L Wines.
And he brought some amazing Bordeaux's. They were amazing.
Yeah, and a lot of it.
$400 bottles. It was.
He brought some
great time.
collection of Bordeaux's. And also, I want to thank not only Sheila, but Danny Gasparini, because the two of them, and Tina here.
And Tina. Yeah.
But it was a fantastic afternoon. Yes. Rick, and we have a picture with a dolly or a car. Anyway, thank you to everybody, but especially K&L. And again, send me your email address if I don't have it already.
But thank you to Sally, big time.
Absolutely.
Thanks, Sally. So a huge thank you to our panel, Dr. Billings, Joanne, and Alex, remind me how to pronounce your last name again. Aleshin? Aleshin. For coming out and talking to us about what's coming down the pike. You know, we always talk about hope on the horizon, and I think being able to monitor potential progression of disease is important for everyone in the room and everyone yet to be diagnosed. So thank you for everything you guys are doing.
This is big stuff.
Yeah, it really is. It really is.
Important stuff.
Of course, you guys know I have to go through my list of things to go through. So our next living room will be March 18th in Arizona. So anybody who's online watching from Arizona, please come out and join us. You can email Michelle or check out our website to learn more about what we're going to be doing at that regional event out there. And then the next San Carlos one is March 19th, and Dr. Carbone, who has been here to speak before, a medical oncologist from Ohio State University, will be out joining us for the San Carlos meeting. And then March 26th, so we literally have boom, 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 like 3 in a row, 2 regional, 1 here. We'll be in Dallas, Texas, working with Presbyterian, UT Southwestern, and Baylor University, with some docs from there hosting our regional meeting out there. So anybody watching from Texas, please, again, reach out to Michelle or myself, and we'll tell you all about it. Events coming up, going back to Arizona in Peoria. We're having our 5K February 24th. This weekend, I will be there, so anybody online, please come say hi. I'll be in the patient support tent, so come by and say hello to me. Gainesville, Florida, with our friend Karen Gornberg, March 2nd. And then Sacramento, California. So any of our Sacramento friends or anybody from the Bay Area who wants to come out to Sacramento to join us, that is on March 30th. So all of that is on our website, on the events page. There's a big fat list for those. So, oh, Katarina, yes, it was so nice to see you down in LA. We got to chat for just a little bit. It was a rainy day, but it turned out to be a really, the sky opened up like right at the kickoff, and then it started raining again as the last person was coming in. But it was a really great event. Yeah. Thank you to Penn TV. You guys, Texas? As always. I already said Texas.
You said Texas?
The living room in Texas. Oh, that one's not till April. I'm not going to talk about April till March. It's too far away for people to remember. Yeah. Thank you to Penn TV, who comes out here diligently every month and sets this up for us. You guys are fantastic.
You know, and this is a TV station, and if you go in that room, this looks pretty simple out here. You go in there, and it's like they bring their entire setup.
Mike's trying to film it, but Rocky doesn't have the screen on.
He's trying to film it. Rocky doesn't have the screen on. This is.
They do a great job, and not only that, for those of you who don't know, they will replay this on Channel 26 all month long. So,
if you're up in the middle of the night, and you know you can't.
Chances are you'll catch this.
Totally.
Yeah.
Totally.
Big thank you to the Office Bar and Grill for pasta night once again. Staff, ALCF staff, thank you all for your help and support throughout all of this event. I know it takes a village to put this all together. Really appreciate it. Again, our panel of experts, including our patient expert, for coming in and talking to us tonight.
And our super duper patient.
Mm-hmm. Yeah, and most importantly, to our patients. This is, again, I said it at the beginning of the meeting, but we bring this to you. So we hope you continue to get enjoyment out of this. And if you don't, please tell me off camera, and we'll fix whatever needs to be fixed. But we're happy to be able to bring this to you. And we can only bring it to you because of the generous support from AbbVie, Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Celgene, Dignity Health and Catholic Health Initiatives, Genentech, Lilly, Medtronic, Merck, Novartis, Takeda, and Tesaro. That's a list of all the heavy hitters working in lung right now, and they all know how important this meeting is, and love to be able to support it for you.
And they just all believe in the patient voice and how important it is.
Yep, absolutely. So thank you all. Please help yourself to dessert and mingling. If anyone online or in the room didn't get to ask questions, again, not to bombard Michelle with emails, but if you just shoot them the emails, we'll be sure to get them out to our panel and see if they can't get some of those answered. So. The whole meeting will be online. The live version, the 2-hour version, will be available fairly immediately, and then the edited version takes about 3 weeks. And if you need it in Chinese or Spanish,
you'll have a link to the live version.
Yeah.
So you can download that.
So thank you, everyone. Come now eat cake.
Thank you.
Well, thank you. Okay. I mean, that was great. I think
it worked.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. Yeah, we can both be heroes, like soldiers in their nice clothes, like soldiers in their nice clothes, together. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this, like sailors in a tempest, like sailors in a tempest, together. And it could be just you and me. We'll be family. Just wait and see. So I'll be brave if you're brave. I'll be brave, but only if you're